All right, today we're going to dissect a true nephrology emergency. We're moving past the textbook pages and right into the thick of it, analyzing a case of catastrophic kidney failure where every single minute counts. We're talking about a high-stakes race against the clock, a condition called rapidly progressive glomerulonephritis, where the fight for a person's kidneys is literally won or lost in a matter of days.
So get this, our patient is a 22-year-old woman who up until this point was in perfect health. She shows up in the emergency department with a creatinine of 8.9. Now, just for context, a normal level is somewhere under 1.2. So this isn't just some minor kidney issue. We are looking at a near complete shutdown of her renal function. And the scary part? It all happened incredibly fast.
And when I say fast, I mean the entire history is crammed into just 10 days. It started with something that sounds so minor, a little periorbital puffiness, some swelling around the eyes. Then she noticed her urine was dark, but just once. A couple days later, her feet started swelling, she wasn't making much urine, and her blood pressure was up. In a little over a week, she went from totally healthy to critically ill.
Okay, so before you even start thinking about what's causing all this, there are three immediate, absolutely non-negotiable safety checks. First, you get an ECG to look for signs of high potassium, that's hyperkalemia, which can cause a cardiac arrest right then and there. Second, an arterial blood gas to see just how bad the metabolic acidosis is. And third, you have to assess her fluid status. Just because she's swollen everywhere doesn't mean she's overloaded on the inside. A quick ultrasound of her IVC is critical here.
So, once the patient is stabilized, we can finally pivot to the big question. What on earth is going on? I mean, the whole picture, a young, healthy person whose kidneys fail over days to weeks, it's pointing squarely at a rapidly progressive pattern. We're not just treating a lab number here. We're dealing with a full-blown clinical syndrome.
So the next obvious question is, does she need dialysis right now? And this is where it gets really interesting. That creatinine of 8.9 is alarming for sure. But, and this is critical, that number by itself is not the reason to start dialysis. The real trigger is the clinical syndrome of uremia, the systemic poisoning that happens when the kidneys can't clear toxins anymore.
And this is exactly what we need to be actively looking for. Is she confused? That could be uremic encephalopathy. Does her breath have a certain smell? That's uremic haustosis. Or is she itching uncontrollably? Maybe there are more serious signs, like inflammation around the heart, gastritis, or even bleeding issues. If you see any of these, it's an absolute no debate allowed indication to start dialysis immediately.
So our leading diagnosis here is rapidly progressive glomerulonephritis, or RPGN for short. The key thing to remember is that this is a clinical syndrome defined by its timeline. The definitive proof, the smoking gun, comes from a kidney biopsy that shows this hallmark finding of extensive crescent-shaped scars in the glomeruli.
And this is what takes us from a strong clinical suspicion to absolute certainty. It's the kidney biopsy, and specifically the immunofluorescent staining that lets us classify what kind of attack is happening at the cellular level. And once we know that, we know how to treat it. The way it's classified is actually really elegant. You have type 1, which shows this smooth, clean, linear line of antibodies along the kidney's basement membrane. That's classic anti-GBM disease. Then you have type 2, which looks lumpy and granular under the microscope. That points to an immune complex disease like lupus. And finally, there's type 3, called pauciimmune, where you see almost no immune deposits at all. That's a huge clue for something called ANCA vasculitis. And, age gives us some major clues too. If you look at all patients, type 3 is the most common kind of RPGN. But in someone under 20, like our patient, the odds shift. Type 2 becomes much more common, and that's mainly because lupus is more frequent in that younger age group. Now look, all three types are devastating. But for the rest of this breakdown, we're really going to focus on type 1 RPGN. Why? Because it gives us this incredibly stark example of just how fast and severe these conditions can be, especially when it shows up as Goodpasture syndrome, a full-on multi-system catastrophe hitting both the kidneys and the lungs at the same time. So what's actually happening at the molecular level? Well, it's remarkably specific. The body's immune system creates these antibodies that attack one tiny little thing, the alpha-3 chain of type 4 collagen. And it just so happens that this specific protein is a critical building block for the basement membranes in both the kidneys and the lungs. That's exactly why both organs are under siege. But here's where the biology gets really fascinating. Just having the antibody floating around often isn't enough to cause the disease. There's this idea called the second hit hypothesis. It suggests that you need some kind of environmental trigger, a second hit, to damage the basement membrane first. That damage unmasks the hidden collagen, and then the antibodies can latch on and start the attack.
So what kind of triggers are we talking about? Well, the biggest one, the most well-documented, is smoking. The damage from tobacco smoke can be that second hit that kicks off a catastrophic hemorrhage in the lungs. But other things can do it too, like exposure to hydrocarbons or even just being fluid overloaded or having a lung infection.
If you really want to grasp just how terrifyingly fast this disease can be, let me tell you about a case from this source material. It's about a man in his early 30s who comes in with what looks like RPGN. He gets stabilized and is taken for his very first session of hemodialysis. About 20 minutes into the procedure, it happened. The report says the patient suddenly sat up, developed severe coughing with blood, collapsed, arrested, and died within seconds. It was a massive, fatal bleed into his lungs. A later biopsy confirmed he had good pasture disease. It's just a chilling reminder of how lethal this can be. And that story perfectly illustrates the central challenge we're facing here. The disease moves at lightning speed, but our diagnostic tools are, by their nature, slower. And it's in that gap, that mismatch in time, where permanent organ damage happens. You've heard time is money, but in nephrology, time is kidney. I mean, just look at how this plays out in a typical case. Day 1, the patient arrives. They start dialysis. Day 2, another session. You have to get their toxins down before it's even safe to do a biopsy, so maybe that happens on day 3. Then pathology needs a couple days to process everything. So by the time you finally have a definitive diagnosis on day 5, 4 or more critical days have just vanished. And what's the consequence of that delay? On a microscopic level, it's devastating. The active inflamed crescents that might have responded to treatment have already started to harden into permanent fibrous scars. You see atrophy in the tubules. These aren't signs of a fight, they're signs of irreversible damage. We may have won the diagnostic battle, but we've already lost the war for that kidney. But what if you could get ahead of it? The source material tells us incredible story of one single case. A 20-year-old woman showed up with early signs, weird stuff in her urine, a little blood in her sputum, but her kidney function was still totally normal. The doctors acted on high suspicion alone. They started plasma exchange before her kidneys failed, and her creatinine never rose. It was the only case the lecturer had ever seen where kidney function was completely saved. So, this forces a really tough question, right? Who do we treat this aggressively? Well, we focus on the patients who still have a fighting chance. If there's active bleeding in the lungs, that's an absolute reason to go all in. And for the kidneys, you're looking for good signs, like a creatinine below 5.5, the patient still making urine, and a biopsy that shows the damage is still active and cellular, not scarred over. The treatment itself is this powerful, three-pronged attack. First, you do plasma exchange to physically pull the attacking antibodies right out of the blood. Second, you hit them with high-dose steroids to shut down all that inflammation. And third, you use a drug like cyclophosphamide to stop the immune system from making any new antibodies. And so this all leaves us with one massive critical question. We are all taught to wait for that biopsy, for that pathological proof, before we start these powerful, potentially toxic treatments. But in a disease where the window to save the kidneys can slam shut in just a few days, is our diagnostic standard, our need for certainty, actually fast enough?